All right. Should we get started? All right, so we finally got to the vascular stuff. So there's some cool vascular stuff we'll talk about here at the end. I love vascular procedures, and I think, again, this is one of the areas that I think has seen the biggest expansion over the last 10 years or so. So I'm excited about continuing to see where these things go. I'm going to show a bunch of case examples today because these are not that common of cases that we see, but they oftentimes have a similar approach to them. And I think as you do more of these cases, you start to have a way that you handle them more and more. And I think that's some of the things that we'll talk about today. So I'm going to focus on arteriovenous fistulas and malformations and look at their intravascular therapies. I say intravascular, there's a little bit where I'll deviate and talk a little bit about some of the surgical approaches to these because we do some combination therapies in some of these cases as well, and so we'll look at some of those examples. So what are vascular malformations? I kind of start with this lead off because when we think of vascular anomalies, the term vascular anomaly is a nice kind of catch-all to use to describe all of these things we see. What's the most common vascular anomaly that we see? Shunts, right? We see portosystemic shunts, not commonly when you look at the numbers, but something that fairly regularly we will see these cases. So usually, most commonly, they're extrahepatics. We tend to see a lot of intrahepatics because of the doing the coil embolization. So thankfully, because I love them, I usually see a couple a week kind of thing. So it's a nice thing to kind of accumulate over time. But the ones that we'll focus on during this chat today are mostly those non-venous to venous connections and mostly looking at the true arteriovenous ones. And so vascular anomalies, that kind of global look, that term that's out there to describe these includes both these vascular malformations where an artery connects to a vein either as a single unit or as multiple branching vessels, but also includes these neoplastic or neoplastic-like lesions. And so when we think about those vascular malformations, there's a little bit of debate about kind of the terminology for that because there's a certain condition that humans often will develop called hemangiomas. And usually these are not things that are present at birth, whereas oftentimes arteriovenous fistulas and malformations are. They have this proliferative phase where they can get really, really large, and then oftentimes can involute, so they can go away. And so in humans, they have to put some time and effort into trying to determine whether a vascular anomaly that they're seeing or vascular malformation that they're seeing is actually hemangioma, because hemangiomas you wouldn't actually treat. I just saw the first case that I think might actually be a hemangioma in terms of this. Obviously, we see hemangiomas that are the more benign version of hemangiosarcomas. We see that as like a neoplastic lesion. But I actually saw a case the other day, a vascular anomaly, that I think might actually be a hemangioma behind the orbit. So it's kind of an interesting thing. I haven't seen any other cases like that. So when we're talking about vascular malformations, how do we define these more specifically? We can look at their endothelial characteristics and we can also look at their blood flow rate. And these are important to think about because these really do determine what treatment options you might go for. And so most of the ones after the venous to venous malformations that we see with shunts, usually again we don't refer to those as malformations, but the venous to venous ones that we see, the artery to venous ones are most common. Capillary, lymphatic, very, very unusual. I think we see some level of lymphatic ones. What's more important in characterizing these is oftentimes their blood flow rate. So when you look at the flow rate through something like a portosystemic shunt, it's very low. The blood pressure in the vena cava at the level of a portosystemic shunt might be 4, 5, 6 millimeters of mercury. In the shunt itself, it's similar. It's only like 1 to 2 points, oftentimes higher. It's a very, very slow pressure going through there. The flow rate through these arteriovenous malformations, though, is very fast. And so that's a big determining factor in what you're going to do for treatment because it means that if you inject something into it and that thing doesn't polymerize quickly or doesn't stop quickly, it's going all the way through. It could go all the way through from the artery to the venous side, and then once it gets onto the venous side, that's where things get dangerous because then it heads to the heart, right? So if you're in the artery side, you worry about the end-on embolization of organs. If you're on the venous side, you worry about it going to the heart. and to the lungs. And so you kind of think about it like that. The end organ for the arterial side is whatever that organ is that you're nearby. Hepatic artery, it's the liver. The gastroduodenal artery, it's the stomach and duodenum. But once you go into the venous side, let's say you're putting coils into a shunt, the end organ for that is going to be the heart and the lungs. So you kind of think about it in terms of that. And that's where these flow rates become important. Usually arteriovenous malformations are a high flow, and so that's why it determines what we're going to use for our treatments, and I'll talk about that. So historically, a lot of these cases have been called arteriovenous fistulas. The reality is arteriovenous fistulas are extremely rare. In the scheme of things, while all of these malformations, all these anomalies are rare, arteriovenous fistulas are super, super unusual because it's a single anomalous connection between an artery and a vein. What we usually see is an arteriovenous malformation, which is where you have an artery, main artery, and a main vein, and then you see this crazy amount of blood vessels that connect them. And so when I'm talking to owners, I use my arms and my hands and I say, imagine this is an artery, this is the vein. They should normally go to whatever the organ is that they're supposed to go to. What happens is they have all of these connections between them, and that's literally what it looks like. When we're thinking about this, most commonly, we see them in the limbs and we see them in the liver. When you look at a liver that has an arteriovenous malformation, it's very commonly coming from the hepatic artery, and then it's going into the portal vein. And so if you look at that, you see all of this crazy blood supply coming off the hepatic artery, and then at some point it becomes portal vein, and then it goes down and into the portal vein. So that's what it looks like. It looks kind of like that accumulation of vessels there. Most commonly in vet med, it's in the liver, but we often see them occur in the limbs, and probably that's because that's where owners see them. There's probably more that happen in the liver that we don't know about because they're subclinical, or they don't work them up. They get a big massive ascites or something and they don't work them up. But in the limb, it's common because they'll come in, but their paws are bleeding and they can't get them to stop bleeding. I've had several cases where the owners are like, their paw pad just bleeds constantly, so we just leave them outside because it's easier than having them come in the house and bleed. And then we talk more about it, and you start to look at the limb, and the whole limb is swollen and oozing fluid and looks abnormal, and there's big dilated vessels on it. So it all the picture all starts to come together. Usually they're congenital. And so even when they present later in life, most of the ones I've treated have been older. Most of the limb ones I've treated have been older. A lot of the liver ones are younger. But I still think that they're probably congenital because a lot of them don't have any history of trauma, but they can happen as secondary to trauma. And I have I don't have an example in here. I did treat one. I treated a cranial mesenteric artery to a portal vein arteriovenous malformation a couple years back that happened secondary to a foxtail ingestion. So I don't know if you get plant-ons here or not, but we have plant-ons in California. There's this nasty plant that basically they inhale or they ingest and they travel throughout the body and they just kind of wreak havoc everywhere they go. And so sometimes they get them and they actually come in and they go through the stomach and just end up in the abdomen. And so we had one that ended up in the abdomen and basically caused such a serious inflammation that it caused the mesenteric artery to attach to the portal vein and develop an AVM. So we could see that sometimes happen. All right, so generally speaking, when we're thinking about treatment of these cases, historically it was always surgical. And so you think about it, it makes sense. If you get a limb that has an AVM, it's not unreasonable to do an amputation. That's a reasonable treatment option. It's going to be curative. You're usually going to be high enough. So if you have a distal limb, AVM or AVF, it's not unreasonable to do an amputation as a treatment. So I'll talk to owners about that. I'll say, we have this intravascular therapy that we usually do for these cases. It's something to consider. If in your mind you wouldn't want to risk that there could be a recurrence or that this doesn't work, then amputation is an option. And so that's definitely something they can consider. And usually, again, it's curative. You can do a resection. So in these liver ones, sometimes it'll be isolated to a single liver lobe, and so you could just take out that liver lobe. The thing with any kind of surgical approaches to these is that they are incredibly challenging procedures. So if you do it, you want to ideally be far enough away from the AVM that you're not going to make it mad during the process and it just bleeds like crazy, because it's really hard to stop them from bleeding. So if you're truly at the level of the AVM, that is a challenging procedure. If you're away from it, where you can take a whole liver lobe out or you can do an amputation, that's a different story. It's not unusual for there to be a mass-like lesion there, and then we get referred a case and said, oh, I did a biopsy of this, and it just didn't stop bleeding. And so that's an immediate sign to me that this might be an AVM that's going on there. There's different minimally invasive options. So you could consider alcohol ablation, which is where you do a direct, you can either go in transvascular, pass a catheter into it, and deliver alcohol. More commonly, where we do this is that we'll do a direct stick into these lower flow ones. So if you get a true low flow malformation, you can do a direct stick of it and then just inject alcohol. And so where this might be nice would be either one that's a low flow or one where you can compress the inflow and outflow. Essentially, so you inject it, you're sticking it, you inject into it, you fill it with alcohol, you let it dwell, you take the alcohol out, and then you allow it to reestablish, or you take the compression off. Essentially, you're allowing that alcohol to denature the proteins, hopefully close down or shut down whatever the malformation is, do a lot of damage. You essentially want that alcohol to do a ton of damage in that region, and then you want to remove as much of it as possible. There's this unique scenario where alcohol, when it gets systemic, that it can cause pulmonary hypertension acutely, and so they can die from that. And so that is one big reason why we're really careful when we inject alcohol intravascularly, to be really, really careful. The other thing is when you do it percutaneously, if you get a big burn there from the alcohol or you get a really big response, you can get skin necrosis, and so that's another big issue. But alcohol is not an unreasonable option to consider. It's a nice local injection that you can do. We do a ton of glue embolization for these. It's well controlled. It's pretty well, they tolerate it really nicely. There's not a ton of negative to it. The biggest challenge is that it's hard to use. We started talking about it this morning a little bit, but when you inject glue, the second that glue hits blood, it starts to polymerize. And so when you're using glue, you can't use normal saline. You can't use, you have to use all glass syringes or syringes that are designed specifically for glue. If you use plastic syringes, it'll polymerize. If you use saline, it'll polymerize. So we use glass syringes, or we use syringes that are specifically designed for glue use, and then we use D5W to mix with it, because D5W does not polymerize it. So you have options or ways to try to control glue, and so we'll kind of decide how much of either D5W, or we use another agent called Lipiodol, which we mix with it as well. And Lipiodol is a poppy seed oil. It's mostly designed for doing embolizations and things like that, but it also is radiopaque, so you can see it really well. So Lipiodol will oftentimes take that and mix that with the glue, and a higher concentration of Lipiodol to glue means that it's going to be less viscous, and so we can get more of a distant embolization. So oftentimes for these really small vessels where we think they're going to polymerize quickly, we'll usually do like a 3-to-1 or 4-to-1 mixture of Lipiodol mixed with the glue to try to get it to push out. And I'll show some videos of how the glue kind of comes out and then it basically just stops because it starts to form a cast or starts to form an embolus right there, and so it starts to build up from there. And then I mentioned it earlier too, you can do this ETOH embolization, which is Onyx. Onyx is really cool and a really nice option. It's just super expensive. And so I've had I've been lucky, I've had some contacts that have donated some to me. So I've been able to do a handful of Onyx cases, but it would be cost prohibitive for a lot of these cases. A lot of the Onyx, it's actually really hard to get now. It's been one of the things that's suffered from kind of the global situation with being able to getting supplies. But a vial of Onyx is probably in the range of like $6,000 to $8,000 US, so it's quite expensive. So it's not something that is typically going to be available to us, so that's why we do a lot of glue embolizations. So the Onyx cases I've done have all been donated. All right, so this is Bear. Bear is a big mastiff, has a lot of orthopedic disease, 11-year-old mastiff that came in, 50 kilograms. He also had this 3-year history of a slow-growing mass on the right lateral tarsus. So everybody was waiting on it, thought it was maybe a lipoma or something like that. Came in, here's this mass here on the right lateral tarsus. And so that is there, and so we can see that, but in a second I'll show you the rest of Bear's foot, which is the more concerning thing. So you see this swollen foot, got radiographs just to make sure, because there was some suspicion that this was an AVM. So I took rads just to make sure that there wasn't a previous fracture or that there wasn't a cancer or something there that might have caused an AVM to develop. Because I wanted to see if this was truly something that we thought might be congenital or if this was something that might have been acquired from something happening. And so Bear, we saw earlier, this is his ultrasound. And so the ultrasound right away kind of gives it away that this is some sort of vascular malformation. Something looks very abnormal here. When you watch this go, you can see that there is a lot of mixing of artery and vein blood here, and it's a very abnormal grouping of blood vessels in that region. And so even myself, who's not an ultrasonographer, I can kind of tell that there's some stuff going on there that doesn't look right. And so you can, at first they called it an AVF. So they thought that it was an AV fistula because they thought they could see a clear connection between the caudal-femoral artery and probably the saphenous vein. But then we did the CT, and you have to ignore he's got a soft tissue sarcoma on the other leg. But you can see he's got very, very abnormal arterial blood supply. So all of these vessels, all of these in here are tiny vessels that make up the malformation. And so I usually try to characterize these as much as I can from the CT, but to be honest, at the end of all these CTs, we're like, all right, there's a lot of extra vessels here. I'm not exactly sure what's going on. So what I'm most interested in is what artery I'm going to use to get to see it better. Because once I know there's an AVM or AVF there, I try to figure out how am I going to get access into it, because doing a direct angiogram is going to be your true way to assess these further. Because essentially you're going to come arterial, like once you know it's an AVM, you know that flow is likely going arterial to venous. And so you're going to get arterial as close as you can, do a direct angiogram, and then really assess what this looks like. Because the CT gives you one point in time. It doesn't give you that continuous look at it. And so this gives me an idea of mapping out where to go. And so a couple options then. Once we know he has a distal hind limb AVM, you can come in one of two ways. So this is his paw, and so this was the obvious thing that kind of started to stand out. His paw is super massively swollen, and it was actually at the point where it was so affected that it was oozing out fluid. They waited a while. They didn't want to move forward because they weren't sure what they were going to do, so they actually waited 4 months. And in that period of time, it got to the point where it was starting to ooze fluid out, and so that's when they really, really wanted to move forward. And so the comparison is to the two different feet. You can see why he would have a really hard time walking just with that situation going on. So the left side versus the right side. He developed a lameness during that time. So basically he just wasn't walking on that hind limb. All right, so two options then. You can come carotid and work your way all the way back. The advantage of coming carotid is that you are not right on top of it, so you have more options for potentially equipment and things that you can use. Disadvantage is coming into the neck. It's a harder dissection. Slightly more risk for complications with the carotid approach, or you can come direct femoral. I decided to come direct femoral, and so kind of went reverse direction. You know, obviously we're usually coming femoral and working our way up towards the heart. This time we placed our catheter and went down the leg, so we went into the femoral. And then from there, we're able to start doing some direct angios. And so this was just kind of a look to map out the route we went. We went from the femoral artery, tracked things down, wire down, and then eventually got into this branching vessel off the femoral here, AVM, and we could note that there was a big dilated saphenous vein after this connection with the AVM. And so this was our pre-treatment arteriogram. So nothing really here yet. This is our initial injection into the femoral artery. And you can see those initial branches coming down, your popliteal and your saphenous arteries. That all looks okay. This next one, though, is where we start to notice some abnormalities. So here's your popliteal again coming out, and your saphenous. And then we're starting to see this very abnormal accumulation of blood vessels here. And if you watch closely too, you can see that they actually start to go up immediately. After they go into this little accumulation of blood here, they actually start to drain immediately into the venous system. So here it came down immediately through this branching vessels and then went up. Here's another one, and there's the AVM. And it's so interesting to see this, that at this point, this is the only vessel going down distally. This little tiny branch. So that's the only means of arterial supply that he has at that point going down his leg. And so here's his veins. And so at some point, some goes distally in the vein, some goes proximally. So I don't know what happens there, but essentially it comes from the arterial side of things. It's a branch, I think, off the cranial tibial, comes into this AVM. Some of it goes down a saphenous, part of it goes up another vein, but you can see this big saphenous vein just sitting there under his skin. And so the supply is very, very abnormal and going all different directions. And the only arterial supply he still has going down distally is this single vessel coming down. That's the nidus there. You can see the branching. There's another draining vein. So it actually comes down some of this vein here, and then it starts to come up, this last draining vein also on the back side of the leg here. So just a very, very abnormal arteriogram. All right, so we get our wire and our catheter down, our cranial tibial artery, and so we can do another direct angio there if we need to. That's pretty much the study we just got. And then our goal is basically to get as deep into this nidus as you can. And so you usually can't get across a nidus and then out into the venous system. If you had a true AVF, you could go through the AVF, the single fistula, and actually usually get into the venous system. But for the AVMs, the connections are so tiny that you usually can only get out to the branching vessels. And so if you're in the nidus, you're going to be safe for that particular case. Meaning, if you go into the nidus and you treat the nidus and there's an arterial supply that you're leaving behind you, and also you're not going all the way across to the venous side, and you're only treating the nidus, that part where the true AVM is, and you treat that region, it's going to be a safe region because all of those vessels are abnormal. You shouldn't have those, you shouldn't need those. The only time it would be an issue, which is something I've never seen, would be if there's not actually a normal arterial blood supply. So I haven't seen that. Meaning essentially that artery is going into the AVM and nothing else is going distally. So I don't think that's a usual thing that we would see. Even in shunts where we don't see any kind of branching portal branches, those usually show up after we treat a shunt. All right, so in this case we use the onyx, and so I was just going to use that so you kind of see an example of how that works. It's a combination of ethylene vinyl alcohol, and it's dissolved in DMSO and tantalum power, so it comes in these multiple little vials that you have to kind of read the directions as you're putting it all together. And so we were lucky because we had one of the reps come out, which helped us, but it's something where it's a little bit painstaking, the process, but then it's makes it so easy to use. And so there's different versions of this, just different viscosities that you can choose based on how you need to, or how you actually want to treat them. And so they actually call it lava. As you inject it, it looks black. And so you pull it up, and that's the tantalum powder, that's black. And so that also is radio opaque, so as you inject it, you can see that really well. And so same thing where you have to use the DMSO to prepare. And so you have to give it, they have some, the instructions instruct you how to, like the rate to give it at, which is some ridiculously slow rate that it's like impossible to actually calculate, but basically you're just like giving it super slow as you're injecting it. And the way it works, the reason why it's such a cool product and the reason why they use it for brain AVMs in humans so commonly is that as you inject it, it fills the edges of the vessel but leaves the center open. So as you inject it, you can actually watch it growing. This is another reason why they call it lava. It looks like lava flowing through the blood vessels because it fills the edges so you can see it. But as long as you keep pushing, it keeps the fact that the edges are solidifying, it keeps the internal component to it from solidifying. So as long as you're pushing, it's not going to stop, and you can keep filling from that point. And so this is just the injection, continuously putting pressure in. Nice and slow. We're basically just injecting as we're watching fluoro there. And so here it is coming in. So we have this now. This is the first time we've seen this today. This is a microcatheter. So we've gotten our guide wire access into the cranial tibial artery with the 0.35-inch guide wire, and then placed some sort of angiographic catheter. In this case, we're usually going to use a Berenstein catheter, which has, it looks like a little hockey stick. It's the one that just has that slight curve to it. So that's going to be sitting in the cranial tibial. And then from there, we're going to pass these really tiny wires and catheters. And so this is that 0.14-inch micro wire. And then then like a 2 French, 2.4 French microcatheter, and that just goes directly inside the 4 French catheter. So it's called coaxial selection. We're coaxially selecting it, and so what we've done is essentially pass this catheter in all the way down into the nidus. So that's the guide wire coming out. So the catheter tip is here. That's marking the catheter tip. Here's the guide wire coming in, and so as we're passing it, I'm just passing it all the way down so it gets way out into the AVM. So I'm trying to get it as far out as possible. Once I have it out into the AVM, then I know that I should be safe enough to start injecting an embolic. So I'm going to take the wire out, and now is what I'm going to start injecting. It's a slow injection, so you kind of have to stick with it here. And so we're starting to inject, and here's where it has that kind of lava appearance. As I'm slowly injecting, this is all the embolic. And so the difference in this versus the glue is that the glue would stop right away. But watch in through here. You can see it in a second here. You'll see it start to keep growing. And so I'm just continuously pushing, and as I push, it just keeps filling it. And if I stop pushing, all of this will embolize and form a big embolus. So you can fill the whole thing. You can keep going and safely fill this whole area without risk of worrying that you're going to get it somewhere you don't want to get it into. And so then afterwards, you can see that that area is totally embolized. So now we've done an injection from up the leg again. And so when you come back here, so this is the point, all of this now is an embolic mass. This is all completely embolized. And so now we're going to do an injection again from the cranial tibial artery, and here's where that mass is, and there's no blood flow going to it. So now we see a much more pronounced arterial blood supply coming down, and then we did some studies on the distal limb, and you can actually see the distal limb enhanced now completely. And so you can see again, there's our tip of our catheter for doing our injection. It's getting in, nothing's going through the embolized region. And so in that case, we would hopefully have a complete embolization of the malformation there. And so we were pretty happy with that. And so then we saw him back 2 weeks. This is pre-procedure, so already post-procedure, you can see some improvements in the size of his foot. You can actually bend at his tarsus now a little bit and at his metacarpal phalangeals. And 8 weeks, normal foot circumference was down to, or was at 18, and his abnormal was 22, and this was it at that point. So he's starting to get some good flexion in that foot and was able to walk again. And so essentially what's happening is you're reestablishing normal arterial blood flow and then reestablishing normal venous drainage. Because what happens prior to that is that those veins that the AVM are going into, they become like arteries. So they have such high flow that's going through them. You have the arteries coming in, it goes through the malformation, and then it goes up to the venous side. Those veins, if you look at them on a cut section pathologically, histopath, they look like arteries because they've been exposed to such high flow and high pressures that they've actually changed over into looking like arteries. So it's this perpetuating cycle that as they continue to get flow through, those vessels want to more and more take on that flow, and they can more aggressively do it, and then they keep changing and doing that. And so the idea is to try to change that by removing that connection between the artery and the vein, reestablishing distal arterial blood flow, and then allowing for new drainage to occur. Yeah?
Can be an option to use a coil before
Yeah. Yeah, great question. I think I have some liver ones where I show that. So the question is, can you use a coil beforehand? And so you definitely can. And so where I've had more success with that, so the idea is if you put a coil all the way as distal as possible, then everything that you put in is usually not going to go beyond that coil. So it's called growing up the embolus. So you grow it up proximally to that point. So it's a safety net that you use. In vessels this small, it's hard to get the coils in, and so in this actually, once you coil, you lose the option for getting out more distally. So in something this small, I would usually try to do a liquid as much as possible so that you can keep growing it out into all of those vessels. But that's a really good option, and that's something where in some of these liver ones or bigger ones, we'll coil those first because they're so big. Yeah, good question. All right, here's another example. So this is more of a paw pad one, and this is the more common scenario I've seen. This is a 6-year-old male castrated Labrador, 35 kilograms, 3-month history of spontaneous bleeding from the carpal pad. It's a little hard to see, but had just a bleeding, like an arterial bleed, that would occur here on a regular basis to the point where the owners were just keeping him outside, and basically their whole patio was just covered in blood all the time. So you can see a little bit better there, the spot, again with ultrasound. That one's not showing up. But nice CT on this dog with some reconstruction. And so you can see at the level, so here's his paw pad here, and you can start to see, and it's a little bit grainy, but all of this, that's the AVM all in here. So all this abnormal blood supply all in through the pad there. So the pad itself is completely affected. So again, in this location, I wouldn't personally try to do surgery. You can do pad resections, and then you can reconstruct it from these other pads here. You can do phalangeal fillets and kind of reconstruct that. But this area underneath this pad is going to be so vascular, it's going to be a really, really challenging thing to actually control that. You could do an amputation, though, as an option. All right, so this is when we did a glue embolization. And so we got down into this median artery. This is just an example just to kind of show you. So really pretty contrast images here. I love doing these. You can see the median artery coming in. Now this guy actually has some distal flow here, and that's why his paw looked fairly normal. That's why his he didn't have that horrible like swelling that other dog did, and just had the bleed. Because if you see this, he's got good arterial supply all the way down to the digits, all the way down in here. But right in this region here, right over the pad, this mass of abnormal looking blood vessels coming in there. So this is a true pad AVM, digital pad or paw pad AVM sitting right in there. And so we start, and this is what glue looks like as you inject it. So we've gotten into that selection, we've gotten out, and we have our microcatheter, that really small catheter, all the way down and into it. And we're just going to try to keep pushing as much as we can until we get it to fill, because right there it's pretty much stopped us. And so the glue just polymerizes really quickly. We got it to push a little bit further with some more heartbeats. This is a second selection. So after we did that first one, we did a contrast study which showed that there's a second area that's affected. And so that's what you'll do. You'll get into one area, you'll give glue, and then you'll come back to that bigger catheter, do another injection, and see where there's still arteriovenous, or still flow going really robustly into the arteriovenous malformation, and then treat again. And so we saw a second area. And so then we'll select that, and then glue into that. And so now you can see at the end, this was the whole area that had the arteriovenous malformation, and you don't see that enhance anymore. And so that's your goal, is to try to eliminate any of that contrast enhancement that's going directly into that AVM. And that's why these are challenging, because sometimes those vessels are so tiny that you can't actually get into all them. In humans with this condition, they would just plan on treating them 10, 15 times, just like going really slow, picking out the vessels. That's not an option we have just because of expense. So we have to kind of try to be aggressive from the beginning, but thankfully dogs seem to have a pretty, and cats seem to have a pretty redundant blood flow that goes there, and so they tolerate a lot. And so here in the end, on that last injection, you can see really much improved enhancement of the digits here, and none of that paw AVM is enhancing anymore. So that's kind of the goal here. Can do it in cats too. So this is a cat that did have a pretty extreme distal paw swelling here, was bleeding as well from this carpal pad, and then had a really, really edematous leg. So this one had a more severely affected situation. Again, can ultrasound just to kind of as your initial diagnostic to look at that. And I'm not sure it's that helpful to see that, but and we also have a nice CT here where you can see, if you look closely, the AVM all in through this region here on the pad. Same thing, so pre-treatment arteriogram, very similar looking. In this case, all of this region here is abnormal arterial blood supply. And if you're not as used to looking at these, you might be like, well, how can you tell? Well, you can tell because normally there should be really normal, crisp branching of the blood vessels that are supplying out and branching to each of the digits. There shouldn't be this mass of abnormal looking blood flow right in the middle of these pads. And so you're looking for that abnormality. You can also look for early venous drainage, which again is a sign that there would be an AVM going on there. So the fluoro images here. This is the glue or this is onyx actually. We were able to use onyx in this case. So here's the microcatheter all the way down into the AVM. And you can again see how it kind of has that lava appearance. Like as you're injecting it, it's just slowly pushing it out, filling into these vessels. So we had some initial injection there and filling. And then secondarily, as we're injecting here, you'll start to see it growing down as well. This was after the initial injection. The onyx is really, really radio opaque too, so you can see it quite well. And so as we're injecting, these little tiny vessels are starting to fill. And you just keep continually injecting. You're looking for anything to start coming backwards. So we're still getting some filling in through here. There's some more coming down. The big thing we want to see is we just don't want to see it start to go up the catheter. It's called growing up the catheter or fattening the catheter, meaning you have your catheter in, and if you're injecting and it's going up the catheter, it means that it is totally obstructed at the level you're injecting, and so anything you inject is actually going to go up into the artery that you're sitting in. So that's when you want to stop. So this is a post-treatment, so we're able to kind of keep filling, getting all through this region and filling all of these vessels. And then on the post-injection, a little bit scary, right? Because there's not a ton of blood flow going down here to the distal digits anymore. And so this was the first cat I did, so I was definitely scared. Because I was like, uh-oh, is there going to be any blood supply? And again, this is where I started to learn that they do have pretty good redundant blood flow here because they didn't have any issues with this. I think they start to open up those arteries that they should normally have in that region. So that's limb AVMs. And so again, nice option to consider. Depends on where you're going to go. For the forelimbs, we usually come from the femorals. For the hind limbs, you can either go into the femorals or you can come from the carotid and work your way back. Those are unusual. We don't see as many limbs. We usually see 1 or 2 a year. Livers, we see a decent amount of those every year. Again, historically, again, this surgical ligation, really hard to do unless it's like a single vessel or there's a really big outflow vein. You could do a total liver lobectomy. And if it's just affecting one lobe, my experience is it's not usually the case. Oftentimes it's going directly into the portal vein. And so I don't think that these are typically smaller portal vein branches or smaller hepatic vein branches. I think they're usually going directly from the hepatic artery through the malformation and into the portal vein. And so 2 main treatment options for the liver ones. We can either come in to the arterial side and just do transarterial. I guess you could say 3 options, but we just come in transarterial. You could do transarterial combined with a dominant outflow vein ligation, or you could just do a dominant outflow vein ligation. So it means you're kind of getting to it from all different ways. You come into the arterial side and then you embolize. You go arterial side and venous side so that you hopefully maximize your impact, or you just come venous side. They all kind of have pros and cons. If you're going to go venous side, you combine it with an open approach. So here's a look at a transarterial approach. So let's look at the CT first. So what we're focusing on here is coming cranially. So we have our aorta here. This is going to be our cranial mesenteric. Cranial mesenteric is that one coming off first. And what you almost always notice in these cases is the size of the celiac artery. It's usually massive compared to a typical celiac artery, and it's usually the same size as the aorta. There's your celiac artery. And so that's really, really unusual. It's not usually this big. It's usually more like the size of the cranial mesenteric artery. And so the other thing that's typical of these liver AVMs is that they oftentimes have ascites. So if you see one that doesn't have ascites, it's always a little thing in my mind to wonder if that's truly what's going on, if it truly has an AVM. And so here's the celiac artery branching off. And if you follow that, that should give off the hepatic artery, which again is very large. This is the hepatic artery here. Should not normally be that big. It should normally be the size of this other little branching vessel here, which I think is probably like the gastric artery. So big hepatic artery, still right here, this is it. And then right here, it's starting to look like something's happening. You see this massive arterial supply within this liver lobe, and basically all of those vessels are connected. They're all coming back into that hepatic artery, and then they all come up through this liver here. Very, very big. All of these arteries coming down and through this liver lobe. So it looks like the quadrate lobe coming in. And then if you watch it come through, here's the portal vein. right here. So here's the portal vein, and then kind of coming backwards, watch the arteries connect into that, right there. Coming into the portal vein right there. And so it goes out, comes hepatic artery, goes out from the hepatic artery, up through this whole mess of vessels, and then eventually comes back into this one, which would be probably the dominant outflow vein, so the dominant one that comes out of the malformation, and that actually attaches to the portal vein. And so if you watch it now from the other side, coming in there into the portal vein. So that's an example of a hepatoportal arteriovenous malformation. I'm trying to see if you can see the extrahepatics. Not really. All right, so approach this the same way. So we usually come in from the femoral into the hepatic artery, and your initial injection in the hepatic artery usually shows really kind of very cool thing. As you start to like enjoy doing these, you see some of these cool injections. So what we have going on here is we have actually came from the carotid here down, have looped up into this celiac artery, into the hepatic artery, and so this is a bigger catheter coming all the way in here. It's parked right there, and then we have a microcatheter coming all the way out and into this into this hepatic artery. And so what we're seeing here is this initial injection. This is all in a branching. This is not the main hepatic artery. This is actually out into one of the abnormal arteries. And so this is arterial flow, and you see that be really fast, and then it goes through this mess of vessels, and then you see a big dilated vessel, and all of these are venous drainage. So these are all abnormal vessels going in, and eventually they're going to go into the portal vein. And what we most commonly see is that these cases get hepatofugal flow. So fugal meaning away from the liver, pedal means towards the liver. And so usually when you do these injections, they come in because the pressures are so high. It's usually hepatofugal flow goes opposite through the portal veins. And so that means it has to get back to the heart another direction. So the majority of these cases have multiple acquired extrahepatic shunts as well. And so they have this combination of large dilated hepatic arteries, large dilated celiac artery, this AV malformation, oftentimes an abnormal communication with the portal vein, hepatofugal flow, and then multiple acquired extrahepatic shunts. Yeah?
And is that a contraindication for closing the IVM?
Yeah, and so the question is that an indication for closing the AVM? Yes. No, it's an indication to do it because if you close the AVM, you can reestablish hepatopedal flow. So even though they have shunts, they may still need medical management afterwards, but if you actually reestablish hepatopedal flow through the portal vein, now your liver is going to get normal blood supply.
Because the shunts, the development of the shunts is not because there's high portal pressure?
It is, but it's because there's so much blood flow coming from the arterial side of things.
Once you remove this, there's
exactly.
no risk of portal hypertension, basically.
Exactly. So if you shut it down, if you shut down the communication, good questions. So the questions are about the pressures now that you're experiencing. Because when you have arterial flow coming in, you have really high pressures coming through that. So your blood pressure going through your portal system is very high. If you stop the connection, that artery is now going to go to the liver with a high pressure like it should. And now the blood flow, if you reestablish hepatopedal flow through the portal vein, that should come through with a normal portal pressure. And so now you should get blood supply to the liver from the arterial side and the portal side. And so preferentially, the hope is that it stops going through the shunts. Doesn't always. And so it's not unusual for us to have to do this and then also combine shunt management long term. If you go in surgically, you can actually, if you reestablish hepatopedal flow, you can tie off a bunch of the extrahepatic shunts. So you can kind of do a combination treatment. Does that make sense, everyone? Yeah. All right, so that was the initial injection. And so here's the glue coming in. I think this is a really good example of glue. Because watch what happens here. So as you inject the glue, so focus here on the distal tip of the catheter. Here's the glue coming out. And so it goes out a little bit and then starts to polymerize. And right at this point, it polymerizes immediately. Because watch what happens. It goes out a little bit into that vessel, and then we're still getting flow, and then immediately polymerizes because now it starts to fill this other branch vessel. So now it starts to fill up here. So this is, you have to watch really closely as you're injecting. So now it's starting to fill that branch vessel more, And then now it's starting to come up the catheter. See that there, how it's starting to actually come up the catheter as I'm injecting. And so that's where I have to be careful. So if I'm far enough out into the AVM, I'm not as worried about that catheter, about it filling the vessel. You know, I have the catheter way out into this abnormal artery. And so I don't care as much if it fills that. If I had my catheter parked inside a normal artery and was injecting out the end and hoping it went in further, then I'd be concerned. Let's say I had the catheter tip and it was almost into like the hepatic artery or the celiac artery or something, I would be worried about continuing to inject there if I was getting it to come up the catheter. But because it's still going out, I don't care as much that it's coming up the catheter, but I'm keeping an eye on it and making sure it doesn't come so far back, because I know all of this is abnormal, and so I feel pretty good about letting it grow up that catheter a little bit. What's the downside of that, or what's the concern? If you don't pay attention, you can glue your catheter in. And so the catheter can get stuck. So basically you inject, you want to keep injecting glue till you stop seeing flow. Once you stop seeing flow and you're not advancing any further, you have to kind of jerk your catheter a little bit to free it from the cast, from the glue, soften it up and pull it out. And then you have to pull that catheter out and restart with your injection. So just keep that in mind. These are, you know, that's an important component to this. I haven't glued one in arterially, but I did do a thoracic duct embolization where I glued one into the thoracic duct before. So it's not the end of the world. You just leave it in place. It's just an extra embolic that's in there with the catheter, but I just kind of like cut it off and leave it in there. So it's kind of poor form, so you try not to, but it's not the worst thing ever. All right, so now this is the injection after that glue. And what you can appreciate already is all of this. So these are all now hepatic arteries that have opened up, that are actually making their way to the liver. So these were not there before. And so we also, though, so you can see all of that. See this enhancement? That's the right liver lobes actually enhancing from an arterial blood supply. So we've made some progress. We know now that when we inject into the arterial side of things, that we're getting some arterial blood flow to actually make it to the liver, which we weren't getting before. And so at that point we can decide, is there still blood supply going through the AVM? And there was still a little bit, so we added some more glue out here. So we got another microcatheter out to this point through this bigger catheter and started to fill that with glue. And so you basically, it's called pruning. You're basically pruning your way through this abnormal AVM, through this tree of abnormal vessels. And so this is what you're hoping to get to eventually. So this is then afterwards, all of this area here that has this kind of grainy appearance, this is where all the glue is. So this is all glue in here, and so you don't see any more enhancement, and you see nice arterial branching, more crisp branching. It doesn't have that kind of abnormal appearance going through it. And so you see nice enhancement of all of the liver coming through there. And so that's a pretty good treatment. And then here you can see better enhancement of the liver. So this is all the liver enhancing, the arterial enhancement afterwards. And what you do then is, then after we treat the artery as much as possible, you consider, do I go in surgically and try to tie off the vein as well? The thing that I usually do is I will usually then pull my catheter, my main catheter back, go into the craniomesenteric, and if you do a craniomesenteric angiogram, you can actually get a nice portogram from that. If you come into the craniomesenteric artery, give a powerful injection of contrast and watch it as it goes through the intestines and then gets back into the portal vein, you'll actually get a nice portogram. And so when you do that portogram from that same catheter, you'll see whether the flow is now patopedal or whether it's still patofugal. If it was still patofugal, then I would elect to go in surgically and try to take down that vein. Does that make sense? Because if you don't get it all arterially, then something else is connecting in there. If you're still getting a patofugal flow, then it makes sense to go in and try to take down the vein as well. So this was reported several years back now. 17 dogs treated by either surgery or glue embolization, 13 surgery alone, 4 with glue. And very small case series, but the glue ones actually did better, and so kind of set the stage that this is a nice option to kind of consider for glue embolization. All right, so more recently in these cases, so we used to just do all of them transarterial and then kind of fingers crossed, hope for the best. We've started to attack some of these now with, like I was saying, both a transarterial and an open approach. And so this is another hepatoportal AVM. So I'll kind of run through what we're seeing now. This is the initial injection, and this is a much more clear hepatoportal injection. So this catheter, this is a really cool one. This catheter is up here. So this came from the femoral. So it's up aorta here, celiac artery right where this little deviation is. This is the hepatic artery, and then this is the branching vessel going into the AVM. So during the injection, this initial enhancement, that's the AVM. That's the nest of vessels. They call it the nidus, or the nest of vessels there. And then watch where it goes immediately after that AVM. It goes into this big vessel right here, which is what? It's the portal vein. So it goes through this AVM, immediately fills whatever this other structure is here, which ended up being a large dominant outflow vein, and then into the portal vein. And watch the flow of blood as we go forward in this. Hepatofugal. It comes down here and goes this direction. Some of it goes into the portal vein, so this is branching coming into the portal vein. This should be the left portal vein branch. This should be the right portal vein branch. This is the main portal vein, splenic vein coming off. So some of it does make it to the liver, but a lot of it still goes hepatofugal. And here's the extrahepatics. So if it goes hepatofugal, it has to get back into the systemic vasculature somehow. And so to do that, it has to create multiple acquired extrahepatics. So here they are here. And these connect then, these go from this portal vein and connect into the vena cava. And so if you continue to watch this through, you would see that they would go from here, and then you would see the vena cava traveling up cranially and going to the heart. And so this is during the glue embolization. So we have this bigger catheter at this point here up into this main hepatic artery. Microcatheter is pushed all the way out to here. And so this is a glue embolization. You can see it slowly filling those vessels. And again, we combine the glue with contrast. Since the glue itself is not radiopaque, we combine it with contrast. And you see we get pretty good filling, but that's all we get out of that. So is that enough? I don't know. So I ended up going in because I was still seeing flow coming through. And you can see how crazy these vessels look when you're in there. So big abnormal looking vessel here in the liver. This is a small dog. There's a gallbladder sitting there. So big abnormal looking vessel. And so my goal was to do a combination of transarterial plus ligation of this big dominant outflow vein. So this vessel here corresponds to this one, to this right here, coming back down, this whole area. So that one, it's sitting right under the diaphragm, right under the xiphoid there, which is where we are here. We're lifting up on the xiphoid in the sternum, and that's the vessel sitting right there. And so I have a vascular loop around it, and then that allows me to kind of mobilize it, very, very slow dissection to try to be sure that you don't rupture this thing by accidentally, because you're going to get a massive blood loss in that case. And then we get a couple nice sutures around it, usually use some silk sutures, come all the way around it in multiple locations and really try to compress that down. And you're safe to compress that down. This is a vessel that they're not supposed to have, that's not supposed to be there. And so you can always check. I'll usually I have a Rommel on here with around with this vascular loop. And so what I'll usually do is I keep my arterial axis, and so I'll compress this Rommel down to close it, and then I'll do another arterial injection, and in that case you should see really good arterial flow because it's not going to make its way through the vein anymore. And so as long as you're seeing that and you feel confident about that, you know you can ligate this vessel down. And then this is post, so this is a combination. And so now the good news is that you see this is the hepatic artery, this is where the glue is, and these are all the hepatic arterial branches. So before, we saw it immediately come up through this nidus into the portal vein and then back down this way. The portal vein's sitting over here, but now we're only seeing this hepatic arteries enhance. And you're also seeing nice enhancement of the liver tissue here. So that's kind of what you're hoping to get, is that now we only see arterial flow. We're not seeing that big portal vein coming back down out of this nidus and all the way down there. So I think that's oftentimes how you can get your best outcome when you see those types of cases. All right, any thoughts on the hepatoportal ones? We'll move on to some.
A bit confused the whole time.
Okay.
This is a congenital condition.
Yes.
And can it not be confused by an acquired one where there is microvascular microvascular dysplasia and acquired shunts?
Yeah, so
Very similar happening?
yeah, the question is, can you be confused by microvascular dysplasia? No, because the angiograms and the CTs would not look the same. And so a couple things. So the different categories, you can get like this microvascular dysplasia, this abnormalities that happen at a small level within the liver tissue. There's not really anything CT or angio related that's going to look specific for that. You're going to still have normal portal branching. You're going to have normal arterial branching. And maybe I should step back and just explain that a little further. So usually off of the aorta, the celiac artery, the hepatic artery branches off of that. And so you should normally get about 20% of your arterial blood supply that should come to the liver off of the hepatic artery. 80% of the blood supply to your liver should come from the portal vein. So the portal vein is going to come up and branch, right? It's a very similar location. It's going to take all the blood from the GI tract, the pancreas, the spleen, everything's going to come into the portal vein. That's going to go to the liver. The portal vein has 2 major branches and then a third. So basically 3 branches coming up supplying the liver. So you should have those 3 branches from the portal vein, multiple arterial branches from the hepatic artery. Those 2 things should never communicate. And so as those come in, if you inject it into either of those, both of those should go into liver parenchyma, and then that should drain into the hepatic veins, which should take it to the heart. What we see here is that when we're injecting into the arterial side of things, we see it go into the portal system. So just like in a shunt, if you inject into a jugular vein and come down into a shunt and inject into a hepatic vein, it goes to the portal system. Those 2 things should never communicate. So hepatic artery, portal vein should go to parenchyma and then drained by hepatic vein. Portal vein and hepatic vein should never communicate. And kind of how I describe it to owners, I know I'm like describing several of these things at once, but how I describe it to owners again is the hepatic, the AVMs kind of look like this. The shunts, if you think about a shunt, you have your portal vein coming in, and normal situation, you have your portal vein coming in, you have liver tissue, so it should come in here, and then you should have hepatic veins draining a shunt. So those 2 things should never communicate. When you have a shunt, those 2 things are connected. Hepatic vein, portal vein become connected, and now you have direct flow going from your portal system into your hepatic vein back to your heart. So if this is the portal vein drainage, comes up through the shunt, into the hepatic vein, goes to the heart. And so for the shunts, we come in and we coil off that connection. We'll close that connection down. For the AVMs, we come artery to the AVM into the portal vein. You want to take down this connection in the middle. So those things should never, none of those things should communicate. Artery, veins.
They would never look like an AVM.
Yeah, so the question is, would acquired shunts ever look like an AVM? No, not usually because of their location. So you can get acquired shunts that are actually through the liver, but you're only going to see the flow if you're venous. And so since we're injecting all of these from the arterial side, you know that these are all AVMs and not acquired shunts. Because the acquired shunts, you would have to be in the venous side, in the portal vein, to actually get them to go through the acquired shunts. And so unless the case has a shunt that it's born with, you can't actually get into the portal vein unless you're intra-abdominal. Does that make sense? Because all of the portal tributaries are all intra-abdominal, and so you can stick the spleen, or you could go into the GI tract or something and get into the portal system. But otherwise, there shouldn't be any way to get into that unless something's abnormal.
Is there any cheaper way
Of treating or what? There's no cheaper way of treating. No, I mean glue is pretty cheap. Like I literally use like the skin glue, so it's $1.50. So that's cheaper than $6,000 for the Onyx. But the no, unfortunately, there's not really. I mean, that's where the amputation and liver lobectomy come in. I mean, I have not ever seen personally. I know people talk about doing liver lobectomies to treat these. I've never seen one where I was like, oh, it's just in a lobe and I could just take the lobe out. I haven't seen that. Yeah, no, there's no way. And when they're coming out and they have these big veins coming into the portal vein, like you're not going to just take a lobe out and have that be done. So I'm sure it's happened, but I just don't see those cases. But I mean, amputation for like the limb ones is totally reasonable. Yeah, good question. Yeah? Good thing I saved this one for last.
The bit that I don't understand is how, if you have this high pressure flow that goes them to the portal system.
Yeah.
How come the glue doesn't go to the vein? How does it stop in the AVM?
Yeah. So the question is, how come it stops in the AVM? It's because those vessels are so tiny. Yeah, so you do have to be careful. It's not impossible for it to go through. So the way to maybe think about it is like, the little, so for tumors, we inject tiny particles for tumors. Like we inject particles that are like 100 micrometers in diameter. And so the reason I mention that is that you would never use those for this because they're so small and the vessels are big enough that it would just go arterial, AVM, venous, and go to the heart. And it would shower the lungs, right? Because it would go out into the lung, the tiny vessels in the lungs. So you'd embolize your lungs. And so you have to use something that's going to embolize more quickly. And so glue, that's the advantage of glue, is that once it hits blood, it starts to polymerize. The disadvantage is it's hard to predict how far into the AVM you're going to get it. And there's not a real way to do that. It's a little bit of experience and kind of just seeing which cases, like how small the vessels are and how much you think you can push it in. And so it is possible that it could go transvenous and then actually go venous and go to the heart. And that's something that's described. There's a case report of it going, well, not for an AVM, but there's one where, you know how the thoracic duct dumps into the veins? There's a case report of injecting glue into the thoracic duct and then having that go to the heart and embolize the heart. So it is possible, but it's very unlikely because the vessels are so small. And so as you inject the glue, it usually polymerizes so quickly that the chances of it going through are really low. And it also does bring up the point of putting a coil in. If you're worried, if your flow through the AVM is super fast, you could put a coil in. You just put a big coil in. That coil's not going to move because once it forms kind of a coil, can't go anywhere else. And then that's going to act like a little wall or a little barrier for your glue as well.
And you mix the glue,
Yeah.
D5W,
Yep.
and the contrast.
Yeah, so either contrast or Lipiodol. So Lipiodol is that poppy seed oil, and that's also radio opaque. So you can mix, you have to have some sort of contrast since the glue is not enhanced. And so you're either going to mix true contrast or you can mix Lipiodol.
And it's that like 30.
It depends on how thick you want it to be. So if the flow is really fast, then I will do a higher concentration of glue, lower concentration of Lipiodol. If the flow is pretty slow or the vessels are really tiny, like in that first liver I showed, those vessels were pretty tiny, I will go higher concentration of Lipiodol and less glue so that I can hopefully make it less viscous and I can push it out further. Yeah. Yeah. Questions? All right. So, and that note, if that didn't make you say what's going on here, here's one in the brain. All right. So this is kind of this is the next level up from the liver. So here's a dog with a brain AVM. And so this is the only one like this that I've ever seen, but it's pretty dramatic. This is a 6-year-old German Shepherd who you could see how exophthalmic the eyes are because the venous drainage, this is actually an AVM that's coming in off the maxillary arteries and off the carotid arteries into the venous sinus drainage within the brain. And then it has these massive draining veins that are sitting behind the orbit. And so it was really causing him a lot of pain, dolomentation, lethargy. He was actually blind because his globes were so severely affected from all the pressure. And so MR'd him in an intracranial arteriovenous malformation. And so as we come in here, you can start to see the brain coming in here. And then right through this region here, you can see this abnormal vessel right in there coming into the brain. And so that's going to travel through. You can see it kind of continue on. And we don't catch his globes all the way there, but eventually you can see big dilated venous structures sitting behind the globes that are really putting a lot of pressure out on his globes. And so there's a malformation of both maxillary arteries, the internal carotid arteries, and the basilar artery. Here's a better look at that. All of this is making up this AVM within the brain. So large abnormal collection of vessels here and here. And so we did a direct angio, so we came in this femoral and did a common carotid artery injection. So just have the skull sitting next to it, so it kind of makes sense anatomically where we are. And so where we are is that his bulla are here, and we're doing an injection into his common carotid artery. And what you see is all of this abnormal blood flow all through this region here. So this is his sinuses. These are fairly abnormal, but you immediately see it go from the artery, and then he gets venous drainage. These are his jugular veins out here and here. And so he immediately goes into the sinus and then down into his jugular drainage. From the lateral view, you can see it a little better. There's the carotid injection. And so this is normal. This is the normal maxillary artery coming up here, but you immediately see it filling this vein within his brain. And then he's got all of these really, really dilated venous structures all through there. The single carotid injection on this now on the right side, I'll show this one here. Right side, again, immediately into the venous drainage, and then back down here through the jugular. So it doesn't go up and fill. It doesn't give blood supply to the nose. It doesn't give blood supply to the skin or anything up cranially or rostrally. So you lose all of that blood flow. And so the biggest issue he had was he had these dilated venous drainage. So again, that's one of the compensatory things that happens because there's such a high level of arterial flow going to the veins that the veins compensate by getting very, very dilated, and they arterialize. They become like arteries. And so here's that AVM. This is a paused image over that. So the normal maxillary artery here, the injection coming through that region, all of this is abnormal blood flow here. And so obviously this is a tense little injection here. We used the onyx for this. And so we had some slow injections into this region. I did it on a subtracted image, which means I took everything else away except for the contrast, except for the embolic, and so you can start to see it. That's filling up the maxillary artery branch. And so we ended up filling 3 of the 4 major arterial blood supplies. So they have bilateral internal carotids coming in and the bilateral vertebral branches and then the basilar arteries. So they have 5 major branches coming into the brain. So as opposed to humans, where we really rely on our internal carotids, dogs can sacrifice their internal carotids and they can get supply at least from a vertebral artery. So we ended up taking out the major branches, 3 of those major branches. And so we did a MRI 5 months post-treatment, and then we're thankful that we didn't see blood flow through the AVM anymore. There was still some dilation of a lot of the venous structures, so I don't know that that will ever get better. But we did see an improvement in his eyes at that point. So that bulging and that exophthalmos that he was experiencing prior to the embolization, a lot of that went down, and he was able to start closing his eyelids. He was still continued to be blind afterwards, and he had this like long-standing corneal trauma, which we were treating for quite a long period of time. That's just an example of a brain one. And then lastly, we'll look at this cool one. This was a renal AVM. And so I'm trying to remember why this dog presented. I think this dog this dog presented for just some lethargy and ended up doing blood work on it and noticed some abnormal values. And so we again came in, CT'd this dog, looked at him and saw that he had a large connection. Here's his kidney here, connection between one of the renal arteries that was immediately taking it to the portal system. And so here we are from the femoral artery, catheter up here into a renal artery, and then you see that initial injection, and what happens there is that immediately dumps into this big venous structure. So this all looks good, right? We're coming into the kidney here. You see branching coming out into the kidney. That's normal arterial branching, but you should not see it immediately drain into this large vessel that eventually goes into this large venous structure, and then that actually went into the portal system. So this was an arteriovenous malformation going from the renal artery to the portal vein. So that's really weird because that's like a system, the renal venous system shouldn't even drain into the portal system. So that's a pretty unusual presentation. And so we did a combined approach again. Here's injecting just into the arterial side of things. So here we are injecting, this is the arterial side of things, and then this is the big venous branch. So this is the AVM here. And so we glue embolized this arterial side, which I think is this next one here. And after gluing this one right here, we decided to go in because there still was some flow through this big venous structure, and went in, and here's that big venous structure right next to the kidney. And so you can see all the multiple acquired shunts. So these are all multiple acquired shunts, because what's happening now is it's coming renal artery, going through the AVM into the portal vein, and then the portal vein has hepatofugal flow, so it's going away from the liver. And so again, to get blood back, the body created all these multiple acquired shunts to get that portal flow to go from the portal vein back to the heart. So these are all the multiple acquired shunts. This is the big renal AVM here. That big structure right there. And so basically dissected that thing out and ligated it down. And so here's that all decompressed after ligating it. Kidney sitting there underneath. This is the kidney here, kidneys here and underneath. Ligated that area down. So now shouldn't see any further flow coming back to it. I don't know why I don't have the post, but basically we leave our arterial catheter in at that point, do an injection, and then you see nice arterial supply going just to the kidney and not into the portal system. So that's it for AVMs, AVS. I would say the outcomes are definitely promising, and this is a nice option. We do, this is one of those things where once you start to see these cases, you start to appreciate when they come in more commonly. They have some similar things that you look for between the abnormal liver values, the ascites, the kind of shunt-like signs where they have poor growth, and oftentimes are fairly responsive to shunt medication. So those are all things that kind of point to maybe an AVM going on when they're hepatoportal, or any kind of portal-related one. Obviously, a lot of the challenges, expense, require multiple treatments. It's technically challenging procedures, so that's obviously something that plays a role in here. Patient size hasn't been an issue so far. We've been able to get into the small ones, so thankfully that doesn't seem to be a major thing, but always something that we consider. And so with that, I'm happy to try to take any questions if anybody has any. Sufficiently wore you out after that one. Thank you.
Okay, thank you very much for this inspiring lectures, Dr. Koh. And, bueno, hasta aquí las sesiones de hoy. La cena es a las 8:30, 20:30. A pesar de que el programa pone 20, son 20:30 en un restaurante que aquí cerca, muy cerca de aquí, que se llama Canfarrán. Tenéis la información en los mails que se os han enviado estos días, ¿no? Es muy cerca de aquí, en la rotonda de salida de Rubí. 20:30. Si aún queréis pasar por el showroom, está disponible aún para ver los productos cuando queráis. ¿Vale? Pues nos vemos allí a las 20:30 los que vengáis, y si no, mañana a las 9 de la mañana empezamos con la parte de cardiología. Gracias.
Just really quick, I just wanted to say thank you everyone very much. I had a lot of fun today and enjoyed getting to meet a lot of you, and special thank you to Daniel and to Mariah for inviting me. Thanks for having me. It's been a great day. I appreciate it.
Thank you very much.